Okay, finally, in this talk on indirect and direct monoamine agonists, I want to talk about an emerging area of research that I've been involved in for the last 5 years or so, which is psychedelic assisted therapy. So we'll talk about ketamine, esketamine, brexanolone, and zuranolone in a separate unit. But so I'm going to mostly focus on psilocybin and methylendioxine methamphetamine, or MDMA. So MDMA is being investigated for PTSD, psilocybin being investigated for, among other things, depression. And this is very much a moving target. So depending on when you're watching this lecture, things may have changed. I'll certainly try and update this as things progress, but there's a lot happening in the space, so it's likely that some of the things I'm going to say in here will be outdated reasonably quickly, and I will do my best to kind of augment that information as new information comes along. So let's take a look at these things. One of the things that we need to understand in order to think about psychedelic assisted therapy is that it is a different model than the idea of taking a drug every day. And my friend and colleague Chuck Raison often makes this elegant comparison between a gas grill and a campfire. What the heck am I talking about? So medication, as we think about it now, is more like a gas grill, which is to say, as long as there's gas flowing into the grill, we've got heat being generated and we've got change. The minute we turn off that gas, the change goes away. Now, psychedelic assisted therapy is more like a campfire in that, so obviously, if somebody is taking a daily medication and they stop, it's kind of like turning off the gas to the grill. The change just stops. In fact, it's one of the first things we ask people when they report to us that they're not feeling well, is we say, "Are you still taking your medication?" Now, the psychedelic assisted therapy is more like a campfire in that we kind of set the conditions right. We use dry wood, we set the fire in such a way that it can burn easily, and if we've done a good job of that, then we can set a change process in motion that will continue even after the flame is withdrawn. And we can even perturb that system a little bit. We can take a log out if the fire is big enough and it will continue to burn. And so there is this sort of in this longer tail of the effect. And that's what we're seeing with psychedelic assisted therapy is that we do these treatments, might be one treatment, might be two or three treatments, but in a reasonably concentrated period of time of maybe a few weeks to a few months. And then there appears, when it works, to have this endurance of effect. Now, probably not a lifetime, probably not curative, but maybe anywhere in the range of a few months to maybe even a few years. I think that those long-term effects sort of remain to be fully understood. Let's see what it looks like. So it is a little different than your conventional sort of take a pill every day and come see me once a month or something like that. In this, we're really preparing the stage for a concentrated dose of therapy that is accelerated by a psychedelic drug. And so we have non-drug preparation sessions. Depends on the study, could be anywhere, sort of between 4 to 8 hours of non-drug preparation therapy in which we spend time getting to know the patient. The patient gets to know us. We answer their questions. They understand what the setting's going to be like. We have a good sense, we, the therapists, I mean, having a good sense of what kind of issues might come up for that patient during their session. And then when the time comes to do the dosing, we're there all day. We get there first thing in the morning. We start the dose usually by, say, 8:30, 9 o'clock, and we settle in for the day in kind of a living room looking environment. Might look something like this. And you see the patient here is lying down on a couch. They've got eye shades and headphones on to help them direct their attention inward. There would have been discussion in the non-drug preparation session about reassuring touch, if that's something the patient would want, should they start to feel anxious or distressed. That can always be withdrawn. It's obviously never sexual in nature, but really what there is a lot of sort of holding the space, being present, maintaining a caring and safe environment for the patient to go through this inner experience. And then following the end of the drug, which will wear off anywhere between sort of 4 to 8 hours, it depends on the drug, then a process of integration therapy begins, also non-drug, meeting with the same therapist who would talk about the day's session before. And we'll often have several of these sessions, either at the end of a treatment protocol or in between. If there's so like the MDMA study for PTSD, there were 3 doses, and so we would have integration sessions between those dosing sessions, spread out over the course of generally several weeks. And so all in all, you're depending on the study, depending on the protocol, you're looking at about 20 to 50 hours of sort of concentrated psychotherapeutic work. So really, this is more of a psychotherapy model that is augmented by a medication rather than the other way around. Let's talk about methylene dioxymethamphetamine, MDMA. The chemical name for that is now going to be methamphetamine. That is what's been submitted to the FDA. This drug has 3 different mechanisms of action. The one that most people are familiar with is it causes a big release of serotonin from the presynaptic terminals, and that is how it becomes an indirect monoamine agonist. So that big dump of serotonin is going to go over to the other side. It's going to activate the postsynaptic serotonin receptors, and that's going to account for some of the elevated mood, some of the sort of pro-social effects, and decreased anxiety and fear. The other things that happen is that we get a release of oxytocin, which is a neuropeptide involved in mammalian pair bonding. So when a lactating person releases breast milk and the baby consumes that, both child and parent are releasing oxytocin. So this it, again has a sort of pro-social effect. It tends to decrease the amount of fear that we have and increase the amount of trust that we have. And that, coupled with the release of prolactin, which also encourages this kind of interpersonal trust, is strategically helpful in psychotherapy, especially in people that have had PTSD, they've had trauma, often have difficulty trusting people who they're working with in a therapeutic context. And so the sort of symphony of these 3 uh, neurotransmitters is what allows for these sort of therapeutic effects of MDMA. One of the things that also occurs is that when we look at fMRI scans, so we look at what areas of the brain are either active or less active under MDMA, we see less activity on the right amygdala. And the right amygdala and the hippocampus are areas of the brain that are kind of processing threat, whether that threat is coming from inside the brain or outside the brain. And what this allows people to do is to talk about distressing memories without being so activated by them. Because what happens with a lot of people with PTSD is they get over aroused, they get flooded by these sort of traumatic memories, and they either can't tolerate talking about them or they shut down. And really, what you want to work with in PTSD when you're doing therapeutic work is this state in which people are alert and engaged, but they're not overwhelmed and they're not shut down. So something called the optimal arousal zone. And so it's possible that what's happening with MDMA assisted therapy, it's making talking about trauma more tolerable. This is what the study protocol looks like. So these gold rings are dosing sessions. The studies that I worked on, these were placebo-controlled trials. So people were randomized either to MDMA or placebo. Not sure we were fooling anybody, but that was what we had to do for the FDA. And then those dots are non-drug psychotherapy sessions that go between the dosing sessions. And so you see, there's a lot of work that goes on here over the course of about 18 weeks between start to finish. Of course, you're reasonably wondering if it works, and the data so far appears very positive. So, using the outcome of does the person still have PTSD at the end of the study period, what was found was that about 2/3 of people, a little more than 2/3 of people who got MDMA plus therapy no longer had a PTSD diagnosis at the end of treatment, compared to about 1/3 to close to 1/2 of people who got placebo plus therapy. So there's something quite potent about that therapy. If you just see that even placebo plus the therapy it creates a pretty significant effect. But if you add MDMA to it, you get an even bigger effect, both in PTSD symptoms as measured by something called the CAPS-5, or disability, functional disability, measured by something called the Sheehan Disability Scale. Now, you might be wondering, like, what are people talking about when they're in these sessions? Because MDMA, unlike psilocybin that I'll talk about in a minute, tends to engender more of a kind of a social interaction. Now, people aren't necessarily talking the whole time, but they definitely probably do more talking with MDMA than they do with, say, something like psilocybin for depression. And the themes that emerge from these studies, looking at sort of analyzing qualitatively, what did people talk about? People talk about these sort of themes of being able to tolerate distress and being less reactive to it and being more insightful to their own trauma experience. And sometimes that engenders a kind of self-acceptance and an ability to not see a traumatic event as the defining event of their lives and engendering possibly a kind of a future orientation because, unfortunately, the nature of trauma is that it often makes the future kind of tentative and the past very burdensome, whatever trauma happened in the past. So this maybe allows people to kind of turn around a little bit and face forward rather than the sort of predominant direction of facing backwards into the traumatic past. And that there's also this physical experience of sort of safety and calm that can come about with MDMA. And, this is all very interesting, but does it actually lead to change? And it appears that, from these studies that were done, and they're small, but that people do report benefits outside of the therapy room. So, in terms of improvement in their relationships, more ability to be self-aware, more ability to engage in new things in their lives. This is an interesting study that Bessel van der Kolk and colleagues did, looking at this group of folks that went through this treatment, comparing them to the folks that got placebo, and looking at a couple of different measures. So one is known as alexithymia. Alexithymia is not knowing what you feel. So a sort of absence of lexi, which is sort of vocabulary, thymia, mood. So, when you ask somebody, well, how are you doing? And they say, I don't know, fine. That's alexithymia. And so people that got MDMA assisted therapy had decreases in this sort of alexithymia, and they were more able to express compassion for themselves. So something called self-compassion. So, an interesting pair of findings that may point towards a changed relationship with one's internal experience as it relates to trauma. Want to take a brief visit to psilocybin. So psilocybin, different drug, different indication. Looking at this mostly for depression, may have some utility in the treatment of substance use disorders. There's been some data published on alcohol use disorder, on tobacco use disorder, and there's work on things such as cocaine use disorder. So psilocybin shows up naturally in psilocybe mushrooms. What we use in our lab studies is a synthesized version of that, but it's essentially the same molecule. Psilocybin is a prodrug. You see on that molecule there in the middle on the left, there's that sort of helicopter structure on the top left. That's a phosphorus group that gets cleaved off and it becomes psilocin. So psilocybin is a prodrug for psilocin. And as you can see, it bears a remarkable similarity in structure to serotonin, which makes sense because it activates serotonin receptors, particularly serotonin 2A receptors. It hits other serotonin receptors as well, but it appears that serotonin 2A is critical for engendering a psychedelic experience because if you block that with a drug called ketanserin before you give psilocybin, you don't get any of the psychedelic effects. It's also why serotonin 2A antagonists like trazodone or mirtazapine or second generation antipsychotics have to be stopped before a psilocybin treatment is given because otherwise they would prevent the psilocybin from having an effect. Psilocybin has this sort of mounting body of evidence that started about 20 years ago. Some small studies looking at OCD, another study looking at folks with cancer at UCLA, up to some more recently, some important studies that came out around 2016, looking at people with life-threatening illness and existential distress related to that life-threatening illness being treated with a psilocybin-assisted therapy model. And then out of that came an observation that many of those people, although it wasn't designed as an antidepressant trial, did report improvements in depression. And the depression data that was gathered the depression rating scales showed an improvement in those who were given psilocybin. And that raised the question of, hey, could psilocybin actually work just for plain old depression? And that launched several large initiatives, one of which was run by a company in the UK called Compass Pathways, another run by a nonprofit organization in the US called USONA Institute. I worked on the USONA Institute phase 2 trials of psilocybin for major depression. That has been published. That was published in 2023 in JAMA. And the Compass phase 2 study was published in late 2022. And phase 3 studies have begun for major depression. So very interesting times for this. It would be a deep dive to get into all the reasons why this might have these therapeutic effects, but here's an overview. I'm just going to kind of hit the highlights here. The first one is changing the way that the brain talks to itself. Earlier, I talked about how there's these different networks in the brain, functional networks that where the different areas of tissue will work together to do a task. And one of these is something called the default mode network. And so the default mode network appears to be active when we are kind of introspective, but it can become overactive, or sometimes what's referred to as overstable in depression, particularly when people are having a lot of rumination. So this kind of keeps people in this sort of pathological introspection, if you will. So they're kind of thinking about what a rotten person they are, but they aren't able to kind of pivot and go to their task positive network and do things that are outside of their own head. And so it appears that psilocybin disrupts that default mode network in such a way that maybe it resets after the drug wears off. The brain sort of talks to itself in sort of unusual ways during the time of psilocybin acute effects. And so this is an area of active inquiry. Another possibility is that that psilocybin is a neuroplastinogen, so similar to ketamine, similar to in a faster way than conventional SSRI antidepressants, that we see this activation of receptors inside of the cell which trigger cell growth. So that may be a neuroplastinogen. There's another really interesting finding that came out of a lab at Hopkins looking at mice. So this hasn't been replicated in humans, but then in mice, there are these limited windows of time where mice will learn things from each other. So mice are very social, this thing called a critical window, after which it's very difficult for the mouse to learn those skills. And what they found was that if you took mice that had passed that age and you gave them psychedelics, that you could reopen those windows. You could see the genes that are associated with those windows being open, getting activated and turned on for a period of time following the acute drug effects. And so what may happen is that there is this window of time that opens up, that maybe what we're doing is leveraging that time window in the integration period. Not clear if this translates into humans, but it's a tantalizing finding. Psychologically, one of the things that may occur is that unlike conventional antidepressants, which tend to kind of blunt emotional responses to things, and while they do decrease depressive feelings, often will decrease pleasurable feelings as well. We hear that a lot from patients. They'll say, I don't feel so depressed, but I don't feel a whole lot of anything. Psychedelics appear to do the opposite. So there's a sort of adage that, people don't always get the trip they want, but they'll get the trip they need. And sometimes the trip they need might be facing some difficult things in their life, facing some upsetting emotions. And so it may turn out that one of the things that happens during these sessions is that people are kind of encouraged by the drug, if you will, to look at difficult things that they have been avoiding up until that point. And it may be difficult. We see this a lot in our lab where people get upset, they cry, they have big emotional responses. And maybe going through that difficult experience actually acts almost like you can almost think of it as like a vaccination, right? So when we give somebody a vaccination, we are kind of activating their immune system. We're making it so that they will be able to respond to that threat in the future. But sometimes the intermediary period is difficult. You've got your COVID shot, you felt kind of crummy for a couple of days, but then your body was prepared to deal with that virus should it show up again. So perhaps there's kind of an emotional corollary to that where people go through these difficult experiences under a psychedelic and they feel emboldened and they feel after that, I can do this. I don't have to avoid those strong emotions anymore. And then finally, probably the piece that's, most compelling, at least in media accounts, is really changing the story about ourselves and our lives, maybe feeling connected to something larger than ourselves, some kind of spiritual experience or existential experience, but that there's something that changes about the narrative of our lives and how we are living it. And so probably it's not any one of these things. It's probably some combination of them in varying degrees, unclear to what amount, but some confluence of these things appears to engender in at least some people a fairly robust therapeutic effect. Now, here's some of the actual outcome data. This was that Compass Pathways trial. So in this study, they took people that had treatment-resistant depression and they randomized them to one of three doses. So they either got 25 milligrams, which is a fairly large dose of psilocybin, probably equivalent to about 3.5 grams of dried psilocybin, or they got 10 milligrams, or they got 1 milligram. So 1 milligram was effectively a placebo. And so they compare these, and you can see in this graph, the group of people that got the 25 milligram are represented by that blue line. They had the biggest drop and continued to go out over the 12 weeks of the treatment. Talk about adverse events in a moment. But this was thought to be a relatively successful trial. The study that I worked on, we did a single dose of 25 milligrams, a fixed dose, or you were randomized. So you were randomized to either that or a niacin placebo. So 100 milligrams of niacin, which would create kind of a flushed feeling, a feeling of discomfort, but certainly not a psychedelic effect. And we don't think it has any antidepressant effects. And we ran about 100 subjects with this and looking at some very robust mechanisms in place to really make sure that this data was solid. It was actually quite a challenging study to run, but we did see this significant separation of about 12 points on a sort of standard scale called the MADRS, Montgomery-Åsberg Depression Rating Scale. And we also showed a reduction in disability in the folks that were treated with psilocybin compared to niacin. And the question, of course, one of the open questions right now is how well does this effect endure? This was a smaller study done at Hopkins, looking at people with depression and finding that, for many people even at 12 months, they still had a significant decrease in their depression. About over 50% were still in remission. But there was another group that did need to go back to using antidepressants, about a third of people, which, some might see this as a failure. I actually see this as probably more realistic data. I think we're going to see some people that really respond robustly to this, and other people maybe have a response and then it decays fairly quickly and they need to go back to antidepressants. So I think as we move forward with this, we're going to need to think about more nuanced ways of addressing of integrating, if you will, this treatment into our existing treatment algorithms where it's not sort of a cure or nothing, that maybe this is something that helps people for a period of time. Maybe they need a period of antidepressants. We treat them again. It's uncertain. That's sort of still being hammered out. There has been one study looking at how psilocybin compared to an existing treatment, in this case, escitalopram for major depression. And this one was a little bit disappointing because I think a lot of people expected psilocybin to be markedly superior to escitalopram. But on the primary outcome measurement, something called the QIDS, which is a depression rating scale, there was not a separation between the two groups, not a statistically significant separation. You can see that p-value is less than is greater than 0.05. It's 0.17. So showing that there was not a superiority to escitalopram. Now, the counter argument on this was that some of the other measurements that looked at things, other ways of measuring depression, other ways of looking at tolerability, that escitalopram was inferior to psilocybin, but on the primary outcome measurement, this thing called the QIDS, there was not a separation between the two groups. So this is interesting because, I think one of the things we're going to have to think about is where does this fit into our treatment algorithms? Is this something we should do early on? Is this something we should reserve until people have not succeeded in getting better with more conventional treatments? I think these are all things that are going to have to be sorted out. There has been one study published. We are working on a second one as I speak, a bipolar 2 depression. This is a group of people that have largely been excluded from trials to date because of the concern for destabilizing them, because bipolar 2 folks don't get mania by definition. There has been this one attempt published and the second one coming down the pipe showing similar effects, acute effects of the psilocybin. You see that drop off in the scores immediately following the psilocybin treatment, and then some people sort of persisting, other people kind of bouncing back. So that kind of variance that one would expect to see in a group of people treated with any given treatment. But in general, on average, was considered a fairly successful trial with no significant adverse events. Now, what about bad trips, right? People always ask me this. What if I have a difficult experience? And I think this is worth considering because any treatment this powerful has potential to cause some challenges. And, I sometimes think about when I was a kid and my mom would throw my tennis shoes into the dryer after I'd been stomping around in creeks or something. And, you'd hear that boom, 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 boom sound. And, a difficult psychedelic experience can feel a little bit like your consciousness is tumbling around in a dryer. And, it's worth kind of examining this. So, we know that there is a certain set of side effects that we get in the lab when somebody is acutely on psilocybin. We definitely see hypertension. We see a little bit of tachycardia. People sometimes get headaches towards the end of it. We sometimes get nausea at the beginning of it, along with some sort of physical discomfort as psilocybin comes on. There can be sort of a kind of akathisia, uneasiness feeling. When people are at the peak of the experience, they can have closed eye hallucinations or visual distortions when their eyes are open. And some people do get pretty anxious as a result of these experiences. Can even get, kind of thought disturbed for a period of time, which generally will end as the drug wears off. But one of the things that, and one of the areas that we're also careful with this, if somebody has a personal history of psychosis or a family member, first degree family relative with any kind of psychotic disorders, we don't dose them. But one of the adverse events that's starting to show up in some of these phase 2 studies that's concerning is what happens if you get this very hyped treatment that, Michael Pollan's written a book about. And it seems like there's all these TV shows and media articles about kind of touting it as a sort of cure. But what if you don't get better? And that actually happened in the Compass study, where there were 3 incidents of suicidal ideation that emerged following dosing. And it turned out that all 3 of those people had actually received an active full dose of the drug, but they didn't get better. So this really raises that question of how are we going to safely manage non-responders? Because the hype around this has really created this narrative that this is a cure, and it's not for everyone. There are some people that will get markedly better, maybe for a period of time, maybe for a long period of time, still being figured out. But what happens if you don't respond at all? And that's what happened in that study. So that was a red flag, something that we need to think about. With MDMA, also similar kind of situation. Most of the side effects are showing up at the during the dosing, and because it is a substituted amphetamine, there is these sort of amphetamine-like side effects. Muscle tightness, particularly in the jaw. People generally don't want to eat while they're on it. Some people can feel a little queasy or sweaty. But those things are generally things that wear off as the drug wears off, and the 4 or 5 hours that the drug lasts. When will this be available? Depends when you're watching this, but right now, obviously we can do S-ketamine, we can do off-label racemic ketamine for major depression. That's quite common. Um, there is a promised response date from the FDA by mid-August of 2024. So depending on when you're watching this, we'll see how that all rolls out, to be continued. And then there's these other studies that are further down the pipe. So psilocybin for major depression has entered phase 3 as of the time of this recording. Also, as I mentioned earlier, looking at things like alcohol use disorder, and then these early stage studies, like some of the things we're doing in our lab, looking at psilocybin assisted treatment for eating disorders. There's been some very provocative work looking at treating generalized anxiety disorder with LSD. Lots of stuff in the pipeline. Where it goes to be determined. But this is something that may very well be kind of rolling out in ways that we can't fully predict at this juncture over the course of your careers. So I would just say, really stay tuned for this information. I think there's going to be a lot more to come. So, in closing, the good thing is there's lots of causes of depression. Depression is probably many different illnesses that have a final common phenotype, or maybe not even that common of a phenotype. Some people with depression are very restless and have a lot of uncomfortable energy. Other people with depression are very tired and want to sleep all the time. Those kind of look like different phenotypes to me, but probably multiple different kinds of depression that have been homogenized into this thing we call MDD, but they have different effect, probably different pathways. The good thing is that gives us lots of targets to work with, and I've gone over a lot of these here that are laid out in this diagram. So I think there's a lot of reason to have hope. It hasn't always been as successful as we would like to treat depression. It is a real serious foe that we will encounter for the duration of our careers. I think it's part of the human experience, unfortunately, but I think we are developing new tools, and there's every good reason to have hope that we are going to advance the treatment of depression in our lifetimes. So thank you for your attention and your time. Bye now.